today, after such a good discussion about the patient brought dead, we are going to discuss about the severe anemia, which is another very dreaded conditions during pregnancy and can lead to a lot of problems. And we all know that there are multiple causes of maternal death. In specifically, maximum is 27% is done by caused by hemorrhage, and 24% by sepsis, and in this category, 8% caused by the severe anemia. But actually, in all other situations, anemia is party to many of the diseases. So it's not only that it is 8%, it may be causative in many mortality reasons will be anemia in many cases, whether it is obstructed labor, sepsis, or indirect causes. So next slide. So iron deficiency anemia is defined as hemoglobin of less than 11 gram% in the first and third trimester of pregnancy and less than 10.5 gram% in the second trimester of pregnancy, according to WHO. But practically, we consider it as, we take it that 12 gram%, and our practice is to bring the hemoglobin to the 12 gram%. So next slide, please. WHO classify anemia as moderate, severe, and very severe. Moderate is between 7 to 10.9, severe is 4 to 6.9, and very severe is less than 4, which is actually the cause of mortality. Next slide. An estimate by WHO attributes about 591,000 perinatal deaths and 115,000 maternal deaths globally to iron deficiency anemia, directly or indirectly. There are 4-fold higher risk of preterm birth, 1.9-fold increased risk of delivering low birth weight babies, and 1.8-fold increased risk of having neonatal Apgar score less than 5 at 1 minute in anemic women as compared to non-anemic women. 41.8% of pregnant women worldwide are anemic. About 32.4 million pregnant women suffer from anemia worldwide, of which 0.8 million women are severely anemic. In a systemic review, a dose-dependent relation was observed with the increased dose of iron supplementation and reduction in the low birth weight baby. Next. So first of all, whenever a patient comes to us, we should be knowing that whether this patient can have anemia or not. So we have to look for specifically for anemia in such cases, like vegetarians or vegans. Like in India, it is almost 80% of the women are anemic. So we take it as because most of them are vegetarian or vegans with B12 deficiency, celiac or Crohn's disease, weight loss surgery, ulcers, polyps, low socioeconomic status, high parity, nutritional deficiencies, phytate-rich Indian diets, malaria, helminth infection, and inflammatory or infectious disease, sickle cell anemia, thalassemia, donating blood, being younger than 20. Next. So taking certain medications like people are taking PAN40 left and right in all cases, and lot of antacids, which can also lead to anemia. Experiencing extreme blood loss during a previous pregnancy, women with multiple fetuses, back-to-back pregnancies, severe morning sickness, heavy periods, pre-pregnancy are likely to experience pregnancy anemia. Next. And iron deficiency anemia during pregnancy increases the risk of low birth weight baby, placental abruption, preterm birth, PPROM, poor Apgar score, severe postpartum hemorrhage, shock, maternal death, stillbirth, long-term neurodevelopmental issues in the children, postpartum depression, poor wound healing, maternal and perinatal morbidity and mortality. Next. So WHO has given a model which says that because of the anemia, there is a difference in the work performance, child development, school performance. And if there is a severe anemia, there is a child mortality, maternal mortality, and perinatal mortality. Next. So now we come to the point when there are chances of litigation and how should we go about so that we already are very careful to deal with such patients. So failure to diagnose anemia in pregnancy, especially in first trimester in book patients. So it is a very, very important thing, and everyone should be seeing this very carefully. Failure to prevent severe anemia. If you haven't observed anemia in initial phases of pregnancy, then you might land up in a severe anemia at the time of delivery, which should never happen. Never. Failure to address underlying causes. Sometimes there are patients who, in spite of giving so much of iron and everything, they don't improve. And in any such cases, you must find out the cause for anemia, and a referral to the hematologist is very, very important. Failure to investigate and manage these cases can lead to litigation. However, care must be taken not to miss other causes of anemia, such as sickle cell disease or other hemoglobinopathies. And failure to refer for correct diagnosis in unexplained anemia, failure to manage according to standard operating protocol. Next. Failure to do timely blood transfusion, IV fluids, failure to take consent for blood transfusion, failure to communicate to patient and relatives of likely complications, failure to notice any reaction or complication during blood transfusion, failure to take their consent regarding this communication, failure to do improper monitoring during labor, delivery, and anesthesia, failure to counsel about FGR, delayed milestones of neonate and fetal demise due to severe anemia, failure to diagnose potential cases of PPH and preparedness for that, failure to notice cardiac decompensation during antenatal, intrapartum, or postpartum. The most important cause for litigation is unpreparedness to deal with such patient in labor. Next. So patients have a right to be informed about the risk and benefit of treatment or lack thereof. If a provider fails to adequately inform a pregnant woman about the risk of anemia and this failure leads to harm, it could also be a basis of litigation. Next. So what is the expectation from an obstetrician? Physicians are expected to meet the standard of care in diagnosing and managing anemia. Deviations from established guidelines, example WHO or national protocols, could lead to medico-legal scrutiny. Proper documentation, patient education, adherence to clinical guidelines, and effective communication are crucial for mitigating these risks. Next. So first of all, when patient comes to you, do not miss history and examination. Although HB test is recommended at first antenatal visit, proper history taking and examination for sign of pallor of the eyelid, tongue, nail beds, and palm should be done regularly. Clinical signs are alopecia, atrophy of tongue papillae or dry mouth due to reduced salivation, the restless leg syndrome, pica, fatigue, weakness, shortness of breath, dizziness, and pale skin are the features of severe anemia. Next. And investigate it properly. A primary step in the diagnosis of IDA is to consider the complete blood count, including hemoglobin, MCV, MCH, and MCSC, serum ferritin, soluble transferrin receptor, serum iron and total iron binding capacity, serum erythropoietin, peripheral smear. Differential diagnosis of thalassemia and iron deficiency anemia is of great clinical importance. Mincer index, that is MCV divided by RBC count. It should be, if it is more than 13, it indicates iron deficiency anemia, but if it is less than 13, it indicates beta thalassemia. Next. So prevention strategies developed by WHO comprise food-based approach, iron supplementation, improvement in health services and sanitation. Other strategies, example, control of hookworm, malaria, and parasitic infestations, and also required to prevent IDA in Indian women. Next. So it is the severe anemia which kills the mother and baby. This slide shows that it was 12% in 2000. In 2024, it is about 2%, but it is a red flag and high-risk pregnancy if there is severe anemia. Next. How you triage these cases in severe anemia and what precautions to be taken. Diagnosis and booking, special attention to unbooked patients, proper investigations to be done. Unbooked patients are many times they are the people who are severely anemic, and if we have to really act fast in such cases. Finding out underlying cause, follow up with repeated CBC tests, dietary advice to be emphasized, daily iron folic supplementation. Do not give iron infusion in hemoglobinopathies with high serum ferritin. Recently, there was a patient who, in my Cloud9 hospital, another doctor who gave iron infusion to a patient, and just the day of iron infusion, he got his ferritin test done and it was high, and he made the life hell. That consultant cried a lot because he really abused her very badly. So this is another point. Management according to the stage of pregnancy, IV iron not recommended in first trimester. Counseling and documentation regarding modality of treatment and its consequences. Iron infusion, blood transfusion according to need. Avoid full fluid overload. That is again a very important, because in severely anemic and specifically chronic anemia, if we give blood very sort of carelessly, then we may land up in overlaid and pulmonary edema. Detection of high-risk factors, susceptibility to PPH, deworming all patients after first trimester, delay umbilical cord clamping after childbirth not earlier than 1 minute. Next. So what are the aims for severe anemia treatment? To address the underlying cause and restore normal hemoglobin level as fast as possible. In severe cases, anemia can lead to complications such as heart failure, arrhythmias, and organ damage. Preventing severe anemia should be the goal. On first visit, diagnosing and treatment should be the policy. Consequences of severe anemia should be explained to patient and family, and documentation is a must. Next. Then this is the very important things which we must know when there are the indications for blood transfusion. If pregnancy is less than 34 weeks and hemoglobin is less than 5 gram% with or without sign of cardiac failure or hypoxia, blood transfusion is must. But hemoglobin between 5 to 7 gram in presence of impending heart failure, we should give a very cautious blood transfusion. If pregnancy is more than 34 weeks and hemoglobin is less than 7 gram deciliter, even without sign of cardiac failure or hypoxia or severe anemia with decompensation at any hemoglobin, you have to give blood transfusion. If anemia is not due to hematinic deficiency or it is not iron deficiency, like in thalassemia, patient is very severely anemic, then we must give blood transfusion. Or like in hemoglobinopathy or bone marrow failure syndromes. Hematologist should always be consulted in such cases. Next. During intrapartum period, hemoglobin less than 7 in labor, a decision of blood transfusion depends on medical history or symptoms. In postpartum period, anemia with sign of shock, acute hemorrhage with sign of hemodynamic instability, or hemoglobin less than 7 gram% in postpartum period, decision of blood depends on the medical history or symptoms. A proper informed consent for blood transfusion is must. Next. The most important part is blood transfusion, and many litigation can happen due to the irresponsibly blood transfusion done. And blood should be compatible, ABO and RH assured by cross-matching test. Blood should be free from contamination. Blood should be free from blood-borne diseases. Blood should be fresh, less than 2 weeks storage. High hemoglobin content should be there. You must check all these things and must take blood from a very reputed lab. Next. And what are the precautions during transfusion? No medication should be added to or infused through the same tubing with blood. Lashed ringer lactate injection or other solutions containing calcium should never be added. Blood component should be warmed if clinically indicated. Unless otherwise indicated by the patient's clinical condition, the rate of infusion should initially be slow. Only when patient is very bleeding profusely or something, then you can give a fast blood. Next. Another thing is reaction. And we all know that the blood reaction really gives us nightmares. So the most common reactions are fever, allergic reactions, which are milder one. But the most serious reactions are fluid overload, lung injury, destruction of red blood cells due to a mismatch between the donor and recipient. Rare reaction includes graft versus host disease, whereby transfused cell attack the cells of person receiving a transfusion. Infections, complications of massive transfusion, poor blood clotting, low blood temperature, and low calcium and potassium levels. These are, everything has to be observed and properly calculated before giving the blood. And as in massive blood transfusion, we have to fulfill all protocol of giving fresh frozen plasma, etc. And nowadays, calcium gluconate is not advised in massive blood transfusion, but that is also another point. Next. Labor brings tragedy. Intensive monitoring of vital sign is the key. Prophylactic antibiotics are must. Adequate pain relief should not be neglected. Good documentation is must. Next. No booked or unbooked patient should go in labor with severe anemia. That is the prerequisite to safeguard yourself. Unbooked cases should be thoroughly investigated. Delivery should be conducted in a tertiary care center as far as possible with availability of blood bank. Recently, somebody has told me about a case. The patient died because of the lack of blood transfusion. She was severely anemic, and the only thing the court said that why did you take her to the hospital where blood bank was not available? Blood grouping and cross-matching with availability of blood to be ensured. IV iron blood transfusion according to gestation and severity. During labor monitoring, be careful about decompensation and fetal well-being. Next. Another very important thing is management of third stage of labor. It should be treated energetically, promptly with all usual measures like concentrated oxytocin infusion and packed cell transfusion. Next. Third stage is very crucial. Preparation for anticipation of PPH is very important. All oxytocics, prostaglandins, ergometrin availability should be checked. Availability of blood to be ensured. Anesthetics to be taken in loop. Documentation of each and every event to be done in file with accurate timing. Support team should be available. A second obstetrician may be of great help. Patient and relatives to be counseled thoroughly and written and informed consent for blood transfusion, and any expected complication should be taken. Next. Immediate postpartum period is again equally risky, and intensive monitoring is continued in postpartum period. Madam has already got us prepared with the critical care course, but actually these are the very rarely you face such problems, but when you face, you are in soup. So pulse, blood pressure, respiratory rate, oxygen saturation, auscultation of lung bases and bleeding per vaginum are checked periodically. Adequate rest and measure to prevent sepsis are important. Antibiotics are continued for 7 days. Since these patients are at high risk for thromboembolism, early ambulation is advised. Record maintenance is must. In conclusion, severe anemia during pregnancy can lead to serious complications for both mother and child. And in some cases, these complications can result in medical malpractice litigation if there was negligence or failure to properly manage the condition. Early diagnosis and appropriate management of anemia are crucial to preventing adverse outcome. Next. Mantras for preventing litigations. Anemia should not be missed, especially severe anemia. If diagnosed severe anemia, then correcting HB as fast as possible. Be careful while giving blood transfusion or IV iron. Counseling and documentation is mandatory. Labor monitoring and third stage management should be done cautiously. Puerperium should not be overlooked. Next. A doctor's worst nightmare is a malpractice. This child, because he's slapped by the doctor, is saying it's malpractice. So we can face malpractice anytime. Next slide. This is the situation nowadays. Next slide, Malti. So sorry, Dr. Albert left the practice and is now making more money selling malpractice insurance. And that is the current situation, and we all are so scared of the medical legal litigation that this is the situation nowadays. Thank you very much.